It's a privilege for me to share my thoughts on semi-open primary cleft rhinoplasty in the unilateral cleft patient to this August international audience. I'd like to acknowledge the SMILE train, especially NKUB, Madam, and Wazi, who are fantastic man managers. I really appreciate you. Certainly the West African College of Surgeons. Then to my teachers, some of whom have logged on, Professor Peter Donko, Professor Pius Agbenoku, Dr. Emmanuel Edu, and Mr. Pencil, whom I'm privileged to moderate this session. And lastly, to my hard-working residents and colleagues, my colleagues, Emmanuel Emil Tano, and a resident, Zainab Al-Hassan, Fifi Kojo, and Esti Bochwe. The title of my presentation, as said earlier, is Primary Cleft Rhinoplasty. The outline would follow. One, we'll talk a little bit about cleft rhinoplasty, the anatomy of the unilateral cleft, goals of primary rhinoplasty, types of primary rhinoplasty, the common techniques used in the sub-region. Then my emphasis will be on the semi-open rhinoplasty, some studies, discuss some controversies, case presentations, and conclusion. Next slide. This is not an uncommon presentation in the picture seen on the screen. This is what is typically referred as the cleft nose. It doesn't take a second look of this child to notice that this child has had a cleft lip and nose repair. And this is a common result after a very good lip and nose repair. This is what is described as the typical cleft lip and nose, which is a great stigma to patients with cleft lip who have had it repaired.
Mr. Hoyte-Williams, you can actually control the screen. You have the remote control assigned to you now.
Okay, it's not moving. Okay. Now, the spectrum of this presentation varies in severity. The picture in the screen obviously is probably one of the very mild forms, and some can really be very severe. It's, however, been shown that the most influential factors that lead to this deformity after repair is one, the severity of the cleft, as well as the primary repair technique. We have no control over the severity of the cleft. However, we do have control over the technique. Hence, my aim of this presentation is to share my experience with you on a technique which I found to be very helpful in mitigating this effect. My experience was during my 1-year craniofacial fellowship at the Changjiang Memorial Hospital in Taiwan, where I had the privilege of working with the renowned Professor Philip Chen, who is a renowned cleft surgeon. Most plastic surgeons and most cleft surgeons would know Professor Philip Chen as the author of the unilateral cleft lip repair in the Peter Nelligan series, as well as in the comprehensive cleft volumes. Professor Philip Chen technique, which has been a result of 30 years of accumulated experience with constant evaluation of his results, with his passion and goal to improve the outcomes of primary cleft rhinoplasty, has resulted in his technique, which I'm about to share with the audience here. He emphasized on subunit reconstruction and attention to details. The repairs, therefore, of the nasal deformity in the cleft is very integral and important in achieving a very good aesthetic outcome afterwards. Primary cleft rhinoplasty has been accepted worldwide, and most surgeons I know incorporate this in the repair of the cleft lip. In Ghana, all the surgeons I know incorporate a form of primary nose repair in their repair. And emphasis
on
in this
admit all.
presentation
When it's
will
one,
be
it
on
takes time. You know, I'm sharing my screen, it's distorted.
emphasis in this presentation will be on the unilateral cleft. Now, we may then ask that what is primary cleft rhinoplasty? Primary cleft rhinoplasty basically has to do with the time of the nose repair. Now, when the nose repair is done at the same setting or at the same time as the lip repair, it is termed as a primary cleft rhinoplasty or primary nose repair. Certainly, if time is a factor, then there could be other times. So we have intermediate rhinoplasty, usually between 5 to 11 years, and definitive rhinoplasty. Now let's talk about the anatomy of the unilateral cleft. The presents with a deficiency following components: the skeletal base, mucosal lining, cartilaginous framework, and the overlying skin.
What kind of problem are you having? Just log in. I can't talk to you more.
Now, this deficiency may result in what we see, such as the shortened columella on the cleft side, and the columella also deviated to the non-cleft side, the depression of the nasal tip, and the lower lateral cartilage of the cleft side is depressed and concave, which is seen as the flaring of the ila nasi. The lower cartilage, lateral cartilage of the cleft side also separates from the lower lateral cartilage on the non-cleft side. And lastly, there may be variable kinking at the ila margin or distortion of the ila rim, which we see as the webbing of the ila. This is a schematic presentation of cleft anatomy. We see the depressed ila cartilage. In this diagram, we don't see the separation because they have put a septum there, but there's a separation of the cleft side lower lateral cartilage from the non-cleft side lower lateral cartilage. Therefore, with this anatomy in mind, the goals of our rhinoplasty then becomes: one, repositioning of this separated cartilage, deformed cartilage, into a more anatomic position to achieve a of both ila domes as well as the tip projection. Possible correction of the columella deviation with or without lengthening of the columella, and certainly moving the displaced ila base more medially to reduce the nostril width or diameter to achieve a very symmetrical nose or ala. Now, this is achieved by releasing the fibrous attachments, which is also described as the fibrofatty attachment between the skin and the cartilage, which allows you to reposition the cartilage into its anatomical or normal position. Now, this can be achieved with any of the following methods: closed rhinoplasty, open tip rhinoplasty, which was described many years ago by Reti, or by semi-open tip rhinoplasty, which technique I would share with you in this presentation. In closed tip rhinoplasty, which is the most common method of rhinoplasty, I have seen most of the cleft surgeons in Ghana incorporate. It is achieved through using a sharp pointed scissors and through the lip incisions, an attempt to free the cartilage from the, to dissect the fibrous tissue between the cartilage and the skin. It is done blindly by just feeling and trying to dissect over the dome of the cartilage, and also through the columella to release the attachment to the contralateral or the non-cleft side lower lateral cartilage. The extent is to, as much as possible, to release all the attachments over the alar cartilage and release it from its adherence to the maxilla to allow it to deform or to reshape when the lip is repaired. Next slide, please. In open rhinoplasty, it's the typical rhinoplasty that we know, that's where there's a transcolumella incision which joins two alar rim incisions to expose the whole tip of the nose. Then this allows you to reposition the cartilage and secure it in the new position with sutures. This diagram shows what I just described. So we shall now move on to the technique I'm about to share, the semi-open rhinoplasty. And the incision are two incisions, one on the non-cleft side and one on the cleft side. At the non-cleft side, we use what we describe as the alar rim incision, an incision that goes along the rim of the alar that extends about 3 to 4 millimeters. On the cleft side, we do a reverse U incision, which originally was described by Tajima, a Japanese surgeon. And this incision is about 1 to 2 millimeters higher than the alar rim incision. The dissection of the alar cartilages is through the reverse U incision or the Tajima incision on the cleft side and the rim incision on the non-cleft side. With the incision, the cartilage is visualized and the section is under direct vision, which is less traumatic and avoids the risk of iatrogenic injury to the cartilaginous framework. The whole extent of the cartilage is dissected, and this allows you to reposition the alar cartilage. Then with the new position, you place sutures, 50 PDS, which we call the interdomal sutures, to maintain the new position. In this technique, the cleft side alar cartilage is raised a little bit higher than the non-cleft side. Now, the Tajima incision is used to resect any nasal webbing at the if there is then, and also to create the outline of the alar rim to resemble the anatomic original position, or what we describe as a seagull in gentle flight. This technique also allows you to lengthen the columella. Additional sutures that are put in is called the alar transfixing sutures, which is also incorporated in all other rhinoplasties. This is a schematic presentation of the technique. You see the alar rim incision on the non-cleft side, the tajima incision, which goes higher at the cleft side, about a millimeter or two higher than the non-cleft side. And a direct vision, there's dissection of the fibrofatty layer to separate the cartilage from the skin, as seen in the picture. Then repositioning of the cartilages to maintain the dome and securing the shape with the interdomal sutures. At the end of the repair, we overcorrect the deformity in terms of the nostril height, which you can see in the picture there. The nostril height of the cleft side is now higher than the non-cleft side. We do this in anticipation of a reduced columellar growth if it should occur. And also, there's more, we narrow the nasal width about a millimeter or two more compared to the non-cleft side, and in anticipation of stretching of the cleft side tissue. So after the repair, you would notice that your repaired nostril looks longer and more narrow. The next slide shows the diagram of how it typically looks in the hands of Professor Philip Chen. A number of studies have been done to compare this with other techniques, and notably with the closed rhinoplasty technique. The goal of cleft rhinoplasty is to achieve a more symmetric nose that looks close to the normal as much as possible. In the study, they compared the nostril height, nostril width, can be seen on the next slide actually. And the medial dome height. And in all the studies, it was found that significantly, patients who had the semi-open rhinoplasty with this technique had a significantly improved symmetry from all the parameters measured as compared to those who had the closed rhinoplasty technique. This is a picture of a patient who had a closed rhinoplasty technique, which I must say is a good technique by itself and has good results. But there are some downsides to this technique. Now, using the lip incisions, you'd realize that you are only allowed a limited amount of dissection because you do not want to stretch the incisions too much, which sometimes could result in ripping or trauma to the incisions. You are not able to fix the repositioned cartilage with sutures and with this technique. And this technique, it's by blind dissection and hence prone to trauma to the cartilage and also buttonholes in the skin. Likewise, the alar rim web is not, you cannot deal with the, or it's not addressed with the closed rhinoplasty. These are downsides to the closed rhinoplasty. And these are the things that the semi-open rhinoplasty addresses. I'd like to just talk about the Tajima incision, which has been mentioned. It is also called the inverted U or the reverse U. It was originally designed by Tajima for difficult cases of secondary cleft lip nasal deformities. It starts as a reverse U incision and proceeds along the alar rim. Tajima believed that this incision is not so susceptible to scar contracture or the shortening effects of a contracted columella. In my experience, it was used commonly during the one-year fellowship on the Oriental population, who are also prone to scars and keloids like we are, but that was not a problem. They did not see contractures and scars were not common. Now, in our population, in terms of scarring, if this should be a problem at all, because there are not enough studies to conclude, if this should be a problem at all, I believe it will be in the same magnitude as that of the cleft lip repair, because there are tissues around the same region. The other thing to mention is there has been a lot of studies, animal studies, and notably Macomb and Sawyer, who have found out that long-term studies on primary nasal correction does not affect the growth of the nose adversely. Now, I'd like to enumerate some of the benefits of the semi-open rhinoplasty. One, because the dissection is under vision, you have a clear and less traumatic dissection over the cartilaginous framework. You are able to reposition the alar cartilage, which is key in the nose repair, to its original anatomic position as much as possible, and you're able to maintain this position with sutures. The lip incisions are not overstretched because you don't use them, and the incorporation of the Tajima allows you to correct the webbing at the alar rim and as well as lengthen the columella. These are some pictures of a patient that employed a technique. This is very gross deformity of the nose, as you can see in the picture. In the initial repair, overcorrection, increased nostril height, reduced nostril diameter. You can compare the symmetry, and this is in the center is the patient after 7 months of repair. Other patients, same technique. Always note the increased nostril height. The reduced nostril diameter, and below them are the outcomes after the repair. Yes, so in conclusion with this technique, I must say that indeed, cleft lip and nose deformity repair can be challenging, especially the nasal deformity of the unilateral cleft. And this still remains a great challenge to all cleft surgeons worldwide. Various surgical techniques have been used. Most commonly in nasal bridging is a closed rhinoplasty technique. We have seen that the alar cartilages holds the key to resolving the nasal problems. And the semi-open rhinoplasty technique allows the visualized cartilage dissection, enables you to reposition the cartilage to fix them in the new position with sutures, and has also shown by research to achieve more improved aesthetic outcomes or symmetry, thereby reducing the psychological burden of the stigmata of the typical cleft nose patients usually suffer or endure. Incorporation of the Tajima incision enables you to correct the alar web which occurs and also increase the columellar height. Thank you very much.
Thank you very much, Dr. Hoyte-Williams, for your presentation. I think the floor is now open for questions. There are a few questions, so I'll take two at a time, and then you can answer them. So the first question here from the chat room, and please, if you have questions, please direct them to the chat room now so that we can all hear what our presenter says or our lecturer says. The first one says, Doctor, what time or age do you do your definitive rhinoplasty? What time or age do you do your definitive rhinoplasty? And the second one for now says, can we please have again the explanation of the procedure based on the picture shown? I think the person asking the question wants to see that slide again, and then if you don't mind, you go through your explanation of what is done briefly and quickly.
Okay,
thank you so
very much.
Yeah.
Thank you very much. Definitive rhinoplasty from the literature is usually done at a time where the patient has stopped growing in terms of like no bone growth, bone growth has ceased. And this is usually between 17 years for females and about 18 years for males. In my personal experience, I hardly have patients who come for definitive rhinoplasty. Occasionally, I would see one doing a mission and do, but I hardly have that complaint. Some way, somehow, I believe this is because generally in our population, because of the configuration of our nose, we have a flat dorsum, our tip is not really projecting already. It's not too extremely too abnormal from the cleft nose, and the patient probably tend to accept it, though I believe this can be improved. Now, from the diagram shown on your screen, in the semi-open rhinoplasty, the incisions incorporated one. On the non-cleft side, we have a rim incision. You can point a rim incision. On the cleft side, a reverse U incision or the Tajima incision, which is about a millimeter or two higher than the rim incision. Now, through this incision, using a skin hook to reflect the inferior flap where with the cartilage, you dissect the fibrous attachment over the cartilage, which is seen there, and you dissect completely. The limit is its attachment to the upper lateral cartilage cranially and down to release the lateral attachments from the maxilla, and also in between the medial cruise of the cartilages, you dissect all the fibrofatty tissues. Having done this, you reposition, still with a hook, you re-elevate the cleft side cartilage, which is usually flattened, depressed. You elevate it and using sutures, it's done in a way to reposition it back into its anatomical configuration and also raise it slightly higher than the non-cleft side lower lateral cartilage. Then the sutures are back. Then you might put what we describe as the iliac transfixing sutures. This is one to reduce the dead space, also correct some vestibular webbing that could occur, and also recreate the nasolabial groove. So this is basically a summary of the description of the technique.
Right. Thank you very much. The next set of questions. So we'll give you 2, 3 this time so that you can, so please pay attention. This one says, is there any role for stents in maintaining nostril height and width post-op? Any role of stents used post-op in your procedure? Number 2, what is the disadvantage of early rhinoplasty on the mid-phase growth? I think you touched on that, but this person is asking specifically, so please, if you could, this answer. And then the third one is, does iliac bone graft improve the collapse of the cleft side of the nose? Does iliac bone graft improve collapse of the cleft side of the nose? Please, if you handle these now. Right.
Yeah. I would address the first question of the role of stents. Yes, there's a very important role of stents in this procedure, or in the nose, in every nose repair. In my experience in Changan, nose stents were routinely used. I had a few nose stents, nasal stents. I found it very difficult to use it locally, so I don't use them. But there's a very important role of stents of the nose in any of the techniques, actually. Then disadvantages of mid-phase growth. A lot of studies have come out to show that there's no adverse effect on growth on early rhinoplasty. And a landmark publication was by Macomb and Selya. Now, the third question that asked about iliac bone graft. I've had experience of using cartilage to maintain the iliac rim. No experience with iliac bone graft. One of the professors I worked with routinely harvested the nasal septum and used it on the iliac to maintain the shape of the iliac. So for cartilage, I have seen them, I have tried them, but no experience with the iliac bone graft. I don't know how, maybe it has to be a very soft bone, I guess, because the iliac is quite curved, you know, unless you're talking about using the bone graft as a columellar sprout. But in my opinion, I think probably this would be maybe too early to do in this child, because this child there's going to be a lot of changes and growth in the child at this level, because we do this procedures around 3 months. Yeah, so that would be my suggestion. That probably bone graft may be a bit too much. But however, I've seen cartilage used with tremendous good results.
Thank you. Let me also add that we thank you for keeping to time and allowing us more time for discussions. Let me see. Bright. There's another question here. Says, thanks for the presentation. Please, what differentiates the open rhinoplasty from the semi-open rhinoplasty? And whilst at it, let me add this question, that in your procedure, do you touch the mucosa at all, or you just do your dissection above the cartilage, that's between the cartilage and the skin only?
Sorry, Dr. Faisal, could you kindly give me the first question again?
What differentiates the open rhinoplasty from the semi-open rhinoplasty? That's the first.
Okay.
Yes. And then the second one, did you get that?
No, please.
The second one is, do you do anything at all during this dissection to the mucosa? That's the mucosa attached to the cartilage that you are dissecting.
Okay.
Thank you.
Okay. Thank you very much. The difference between the rhinoplasty pointed to two bilateral rim incisions, and leads to you completely elevating the tip, or the skin on the nasal tip, to expose the cartilage during your dissection. In the semi-open, there's no need for a transcolumellar incision. The incisions are just placed in the alar rim of the non-cleft side, and also on the rim of the cleft side, but this time on top of it, close to the skin. This allows you to resect the excess skin, which usually results in the webbing. I did not dissect between the mucosa and the cartilage. The dissection is only between the cartilage and the skin. And I believe this allows you enough movement to be able to reposition the cartilage into its normal curvature. So there's no dissection beneath the cartilage. Thank you.
Right. Thank you so much. No further questions at the moment, but let me ask one. What sort of sutures do you use for your fixing of your cartilage?
Yes, so we use PDS 50 to maintain for the interdermal sutures, to maintain the repositioned cartilage.
Right. Thank you very much. I think that we've taken all the questions, and there are a few other comments here, all thanking you for your wonderful and beautiful presentation. And then there was a question on the alveolar bone graft. I think
Alveolar bone graft.
Yes, was which you've answered already.
Alveolar bone graft.
Yes, that was the question. The question was
alveolar.
Yes.
Oh, I'm sorry about that.
So the question, let me read the question again. It says,
yes, I was wondering that. That's why I said bone graft in the alar was.
So it's not bone graft to the alar, but it's talking about alveolar bone graft. And the question is, does alveolar bone graft improve the collapse of the cleft side of the nose? But as you said, doesn't.
Absolutely. Absolutely.
It doesn't.
I'm sorry, yeah.
Yes, because, and Prof has given an additional point here. And let me just read it. It says, alveolar bone grafting at the mixed dentition stage helps to support the floor of the nose and maintain height of nose, which is prone to collapse as the child grows. So the alveolar bone graft later on supports the floor of the nose, whilst, as we've already talked about, rhinoplasties, you can do the definitive one later. So once again, thank you very much, Dr. Hoyte-Williams, for this procedure, or drawing our attention to this procedure. I think it's a good one. And since in cleft surgery, no one procedure or no one size fits all, so to speak, we are always at an advantage when we get to know of new things which you, after hearing, can apply when necessary to your patients or your clients. So I cannot overemphasize the importance of these lectures. Recommended to everyone, and call others to join in from time to time. I think this is my last comment. And once again, thank you, Paco, and thanks to WACS and Smart Train for having me as the moderator. And back to Mrs. Obi. Thank you.
Wow, thank you so much, Dr. Hoyte-Williams. It's been a very insightful time knowing about these techniques on rhinoplasty. And thank you again, Mr. Penstiel, for moderating this session so wonderfully well. Next week, Monday, June 22nd, is another time we'll be coming together during the Telecleft session, and we'll be sharing some more insights, some more ideas, some more experiences on how to provide good quality, comprehensive cleft care to our patients. Thank you so much. If you have any questions we couldn't take here, feel free to connect with us offline, and we'll try as much as we can to answer the questions. Thank you so much. Thank you, everyone. Thank you, West African College of Surgeons. It's been a wonderful partnership, and we hope that as we continue with the Telecleft series, many of us will get to know more about cleft care. Have a great week, and God bless you.